to be a part of this uh, major program, that is organ donation web series. Today's talk is on management of brain dead patient and coordination of organ donation, a very important topic. Even though we select brain dead patient as a potential organ donor, we are unable to manage. Sometimes we may lose an important donor who can save so many lives. So regarding this aspect, and also regarding coordination of the of organ donation, we have a subject expert, Dr. Chinnadurai R, lead consultant, critical care, Aster RV, Bengaluru. So we're going to discuss about this topic. To moderate this session, Dr. Ramakrishna ML, Chief Consultant Intensivist, Apollo BGS Hospital, Mysuru, and Dr. Mohan Kumar about to join. We have Dr. Rajini Patange, consultant and also panelist from Mysuru. I will hand out mic to Dr. Ramakrishna ML, sir. Please, sir.
Yeah. Good afternoon, everyone. Let us will not waste the time. So I will hand over the mic to Dr. Chinnadurai. So he will proceed with this talk. He is an expert in this field. So over to Dr. Chinnadurai.
Yeah, thank you so much, Ramakrishnan and Raghu and Dr. Rajini.
You're welcome, Dr. Chinna.
Yeah. So about maintenance, we covered two topics nicely last 2 weeks. This is the last and final topic. So last 4 years, our team have facilitated around 100 donations. In that, we are able to retrieve more than 500 organs. We able to do donation even after 60 minutes of CPCR. After that, we able to revive the patient. And eventually went ahead for heart and lung donations. The donations after prone ventilation, the patient had ARDS because of secondary to pulmonary edema, severe cardiac dysfunction. We able to prone ventilate the patient and proceed with organ donation after 3 to 4 days. And donation after ECMO. Sometimes the patient had a cardiac arrest. We initiated ECMO just for organ retrieval, and we managed the patient for a couple of days. And we retrieve those organs, and we use normothermic organ perfusion machine, and successfully, did a liver transplant. So, how long you have to wait after any major neurosurgery? 4 hours is more than enough. Aneurysm rupture and head injuries up to 6 hours. And in case the patient had a hypoxic arrest because of cardiac arrest or drowning, we have to wait at least 24 hours before declaring brain death. And in case you drug hypoxia, last class we told around 4 days, almost 100 hours for half-life you have to wait. And age limit, though they say there's no age limit, but kidneys up to 60, we can take liver up to 60. If even up to, sometimes if more than 50, if there's some dysfunction, we'll do the biopsy and proceed. Heart up to 45 years, but recently we use up to 55 also. After doing coronary angiogram, which is normal, we proceeded. Lungs up to 60, 65. In case non-smoker, no COPD, able to do that. So this is already Dr. Ramakrishnan, circulated in our group. There's a beautiful article, very short and 6-page article, about this brain death management. So one of the role of intensivist, managing these patients from day one, we created rapport with the relatives. So it is our job to do everything, especially maintaining hemodynamic stability and diagnose brain stem death, certification. Then we know how to prepare the patient's relatives for this news. And we have to start counseling. Then maybe your transplant coordinator, your grief counselors, not transplant coordinator, grief counselors will take over after that. And we, in critical care physicians, we have to lead the show, making policies and protocols, what to do when appropriate time for executing organ donations. And we have to communicate with the transplant coordinator and organ procurement team, various teams from various hospitals. They will call us and coordinate, and about family members when the procedure will be over, and when their postmortem in case needed MLC, then when we hand over, what time they can do the final rites. There's so many things we have to coordinate when for the successful organ donation program. This is simple. Again, the same article says about, in case you detect the potential brain death patients, ABC approach, nothing but we have to find there should be etiology for brain death. For example, any bleed or stroke, increased cerebral edema secondary to hypoxic injury. There should be etiology for brainstem death. If your CT brain is normal, we cannot, we cannot go ahead and declare brainstem death. And alert signs like, patients stop coughing, DI, all that is alert sign. And any contraindication for organ donation, you have to look after the ABC approach. Then, as I told, family counseling and management of donor. This donor is like, we have to treat them as a VIP, because he's equal to 5 different ICU patients. We're going to save another 5 patients, 1:1 ratio, 1 nurse only for that patient. Sometimes we have 1 doctor only for that patient to manage, because every minute, every 5 minutes is so important to manage this patient. It's no rocket science to maintain these patients. The rule of 100 is very easily to remember. Make sure systolic blood pressure around 100, urine output around 100 ml per hour, PO2 level in ABG should be 100, and hemoglobin concentration is 100 grams per liter. That is 10 grams per deciliter, and blood sugar around 100. So this is about we maintain cardiac output oxygenation. That's important. For maintaining good cardiac output, preload should be important. If the patient is hypolemic, give good adequate fluids. Sometimes overzealously we give more fluids. It causes a lot of third spacing. Then they go for pulmonary edema. Then we meditate, so that judicious preloading and contractility is poor. Myocardial contractility, most of these patients go for poor myocardial contractility because of your sympathetic storm. So it should be very carefully manage those situations. Afterload, obviously, when the patient have vasodilation and severe hypotension, so that we have to juggle around with this, with the CVP, with ultrasound guided your LV functions, IVC diameters. We have to give fluids, supports with the lesser PEEP, because we can't go more PEEP in hemodynamically unstable patient, but we have to recruit the lungs. We have to juggle around. And so to start the maintenance, we have to transfer this care, or you take over completely from the other neurology team, neurosurgery team, and you strike down all that mannitol unnecessarily, because once the patient's brain death, just stop the mannitol. No need for your anti-epileptics, all unnecessary medications. We can stop it, take over completely, or new order to be written, establish lines. Arterial line is, and the central line is so important. In case patient need high vasopressor support, instead of radial arterial line, femoral arterial line will give accurate value because of peripheral vasoconstriction. I told dedicated nurse and doctor needed. Make sure this patient not having any other major infection like bowel gangrene, septicemia, other major viral infections, no fungal infections, and other like aplastic anemia. Recently, we had 1 patient willing to donate, but we found aplastic anemia, we refused. And make sure there is no malignancy with the meds. These are the we have to rule out. They're no longer fit to donate organs. So as I told, lines, arterial line, CVP line. If the center where you don't have facility to the at least EJV, external jugular vein, because supports reach easily to the heart. Sometimes we see people starting peripheral line with a very high support. It won't reach heart because of peripheral vasoconstriction. So urine catheter with urometer, every hour you have to monitor urine output. That is very important. If possible, you have nasopharyngeal temperature probe monitor, because your digital thermometer, it won't be very accurate, because these people more prone for hypothermia. If not invasive line, at least NIBP every 5 minutes, as I told, EJV 18 and 16 gauge possible. So monitoring, very simple ICU monitoring, make sure adequate blood pressure, heart rate should be lesser, maybe normal range. Then if not, as I told, continuous monitoring is not possible, at least every 5 minutes, vitals to be checked. Temperature monitoring is very important, because sometimes patients go for severe hypothermia, and that causes your ECG, ACG abnormalities, like a lot of arrhythmias can kill the patient. So what are the blood tests to be done? Most of the, all organ function tests to be renal function, liver functions, rule out infections, In case if it is infections, they treat appropriately. In case the considering pancreas, they'll sometimes ask amylase, lipase, and HbA1c levels. They ask for pancreas patients. Obviously, ABO and blood grouping is important. Other hepatitis B, all infections should be. We have to do that. Hepatitis B positive can donate to B positive. Sometimes we B positive also we take the organs, and we are very good antiviral in the recipients. We can do that. Urine analysis is very important. Urine, especially PCR protein creatinine ratio, if is high, the renal team may ask for biopsy in presence of diabetes and hypertension, any other comorbids in the past. And cultures should be sent. So now come to the specific organ, guidelines. Pulmonary, nothing. We have very good experience of the recent COVID infections. We brought out many patients out after prolonged ventilation, all that. So we do normally ABG every 8th hour, keep on modifying your respiratory rate, and the soda infusion, your acid-base balance should be corrected nicely. When you do the first ABG, sometimes we have to do the 100% FiO2. If the PF ratio is more than 350, the lung team will be interested. So in case sometimes they ask for CT chest, to accurately measure the size and any pneumonia in a consolidation, whether they can targets during bronchoscopy specific lobes to take a sample for culturing. Ensured PP is around 5+. Sometimes we keep basic people for 7. Lung recruitment is not controversial. Sometimes we use every hour, 10p for 10 minutes or 15p for 15 minutes, and do that. And bronchoscopy, routinely we do for most of the patients to clean up the lungs so that it won't deteriorate further. And acid-base balance should be corrected either through ventilator or through soda backup and IV fluids. If not correctable, the patient may need hemodialysis. So chest percussion every 4 hours, just to clear the secretions and turn the patient positioning. And in case nebulization, sometimes if the patient required, if the patient is going to donate lungs, so we start cholesterol nebulization in addition to the other nebulizations to prevent colonization of the bacteria in the trachea. When lung is fit, X-ray CT is absolutely clear, PF ratio is more than 400, and Gram-Stein, no bacteria. Sometimes if the bacteria also there, take it. If there is a lung is fine, culture is negative. Airway pressure should be normal. Sometimes there should not be asthma. Airway pressure should not be very high. Bronchoscopy should be clean. And cardiac, when the obtain echo and electrode imbalance, especially hypokalemia, should be corrected. Hypomagnesemia should be corrected. Maintain proper CVP. Usually, cardiac team ask very minimal vasopressor supports. To achieve that, we give, though we in ICU, we don't monitor CVP routinely, but cardiologists insist at least CVP and maintain adequate fluid. So we normally does IVC diameter and CVP and correlate so that it can be more fluid, reduce the vasopressor support so that you can use the heart also. So heart team needs normal echocardiograph, minimal vasopressor support. And when kidney is fit, obviously you know that normal renal function test, urine PCR is normal, ultrasound kidney sizes and there is no injury is normal urine output. Sometimes if the ATN develops, young patient ATN develops, sometimes after explaining to the risk to the recipients, we still harvest organ and transplant. If there is a really young kidney, normal looking kidney before normal urine output, because of the cardiac arrest, the patient developed ATN, still we can go ahead. Sometimes the team asks for renal biopsy. So be careful when you're doing renal biopsy because of low platelets, they may injure the vessel and sometimes the patient deteriorate because of biopsy. When liver is fit, basically normal LFT, even SGOTPT sometimes uptrend, sometimes starts with 200, 300 SGOTPT. After 2-3 days resuscitation, if the downtrend comes less than 100, they still harvest liver. Sometimes if there is a nodule, because we had 2 days back, we had one liver donation where the patient had a nodule after opening the abdomen, and we did a biopsy, cryobiopsy. Within 1 hour, we got the report. It's not a tumor. So we proceeded with organ donation and successful liver implantation. And normal lactate should be normal. Sometimes lactate goes up to 7, 8. If the lactate downtrend, if less than 4, no need for absolute normal lactate. If less than 4, usually the liver will be harvested. They don't look really very high vasopressor or low vasopressor, because moderate vasopressors is fine. Even 2 vasopressors also fine to go ahead for liver harvesting. Liver biopsy, yes, when the SDOTPT is a little high, we are suspecting maybe the fatty liver, we do the biopsy. If there's less than 30% fat, there is no early cirrhosis, fibrosis, then we will take the liver. This is only important thing about diabetes insipidus. Yeah, patient suddenly the sister comes and tells last year urine output 300 ml look like water. So this is a criteria. If anybody have more than 3 ml per kg per hour, sudden urine output and the sodium level uptrend. If you see urine specific gravity, urine hyposmolality, these are the theoretical part. We routinely don't do all this osmolality. Just simple urine output and hypernatremia tells us there is hidden complications there. For example, because we always say hypokalemia level, potassium level only. These patients sometimes kalemia, potassium level goes to 1, 1.2, severe hypokalemia. Sometimes they takes 200 to 300 microgram infusion required within 24 hours. Sometimes we don't even dilute, just neat potassium through the syringe pump. Syringe pump, we give very rapid correction, otherwise they develop fatal ventricular fibrillation and arrhythmia. So here, what happens most of the time, we won't check the calcium level, magnesium level, phosphate level. Those things also low. So empirically we can give without even checking. There's no harm in giving 1 or 2 doses of this. We can do that. Avoid dehydration. Sometimes the people, they keep writing 100 ml per hour. After 6 hours, go and see the urine output will be 3 liters and intake only 500 ml. And obviously severe hypovolemia, and the patient have a cardiac arrest. Maintenance fluid, no difficulty. Normally we do lactate, lactate. In case hypernatremia, we start with 5% dextrose. In addition to the maintenance fluids, match the urine output plus whatever the loss, depends on sodium. We can calculate your, according to your sodium, we calculate the fluid deficit, and we can correct with free water through NG. Best way to correct this hypernatremia. Maybe you can start with 100 ml per hour, then you escalate to 200 ml per hour. Every 4 hours, aspirate and see whether it's being absorbed. And that is the best way to treat the hypernatremia. If not coming down, you can start with 5% dextrose. But only problem with the 5% dextrose, your glucose level goes up. When you give insulin to reduce this glucose insulin again pushes the potassium inside. So that's what every 4 hours you have to keep monitoring, correct this. I love to treat with more free water than 5% dextrose. And there is one finding, most of the liver transplant units found out, when you give 5% dextrose with the insulin, a lot of glycogen storage happens in the liver, so that the outcome of the liver transplant is good. Even if you see the live donation, liver transplant donation, previous night and morning, the live donor being given a lot of loading of glucose. That is one of the finding I learned from my surgeons. So every 8th hour you can do sodium, potassium, ABG, and GRBS per hourly, and just correct all this little. And about hormonal replacement, obviously we know that vasopressin replacement is very important. See, we do in case if there is no nasal bleeding, no nasal injury, we give desmopressin nasal spray. If there is no hypotension, only hypernatremia, no hypotension, we can give desmopressin nasal spray. If there is hypotension, you can use vasopressin for both controlling the urine output and blood pressure. We can go 1440 up to 4 units per hour. You can go. Then once your DI is cured, then after 2 days they become somewhat is better, so that By the time we'll in OT, there'll be very less requirement of vasopressin. Not everyone develop DI, 80% develop DI, 20% still won't develop diabetes insipidus, but it should be chased. See what happened, your sodium level is so important for successful transplant. If your sodium level very high, your transplant patient sodium level is maintained around 120, 130. The more the difference, the more failure of the graft organs. That's what very important. And methylprednisolone is very important. See what happened. These people initially the brain stem death happens to your midbrain and your pons and medulla dies. After that, what happened? Your anterior pituitary and posterior pituitary hypothalamus dies. That's what patient go hypothermia, and patient can have anterior pituitary hormone deficiency, posterior pituitary hormone deficiency. So they're saying that because of this, during the storm, hypolemia, hypotension, all that, because a lot of inflammatory mediators are released, you have organ dysfunction of donors. So that to prevent a micro level injury, we can give methylprednisolone. Normally, I practice around 1 gram stat just within 24 hours before organ harvesting. But this paper, this article suggests you can give 1 gram, but every day 1 gram. My question is sometimes, so 5 to 7 days, they don't donate. Patient will be very stable. We cannot give 1 gram every day for 5 days, 7 days. This is ideal for if somebody is brain dead and willing to donate within 24 to 48 hours, we can give. There's one more regimen called 250 milligram bolus and 100 milligram per infusion. Insulin infusion, as we all know, we have to maintain with 80 to 150 milligram of glucose. Thyroid replacement, no need to discuss about IV. It's not available in India. What I nowadays started practice slowly, 300 microgram every day. But this article says we can give 300 to 400 microgram every 8th hourly. We can give, especially people with hemodynamic instability. So choice of vasopressors, noradrenaline. In case patient have severe LV dysfunction, we can start low dose of adrenaline that I've seen improves our contractility and reduces other vasopressors. General care of brain death patients, no rocket science. We hand hygiene to prevent secondary infection. If they're MDR, XDR, obviously recipients will be immunosuppressed so that you can cross-infect them through the organs. So be very careful. So better not, maintain very good infection control practice. Line, NG tube, 6-hourly aspirate and see whether your feeds is absorbed. Sometimes the massive vomiting can happen, that can be avoided. Foley catheterizations for hourly monitoring, care of the lines, proper position to improve the lung functions, frequent body change to prevent any bed sores and the secondary infections. Warm blankets so important to maintain the blood temperatures normal. DVD prophylaxis, you can do pneumatic compression. If the platelet is more than 1 lakh, you can give subcutaneous clexane. Eye care is so important to prevent, eye dryness, and we can successfully donate corneas also. Tracheal toileting is so important to prevent lung infections, and lung can be donated. Stress ulcer prophylaxis, sometimes Panadol OD should be fine. Sometimes if the platelets are low, the bleeding chances that you can go for PD doses. Normally, we give broad spectrum antibiotics like Piptas. We give this patients in case you want to, slow grade spike of fever, some organism isolated. We can sometimes add meropenem. If there is a lung, so lung team always insist on, they want cholesterol nebulization. They want meropenem, polymyxin, 1 dose along with fluconazole. We give that. So rule of 100, as I told earlier, the same things to be followed. Systolic blood pressure 100, urine output 100 ml per hour, PO2 100. The hemoglobin concentration is 100 grams per liter and sugar is 100. Thank you so much.
Thank you, Dr. Chinnadurai.
Yeah.
It was a very good presentation. Let us see any audience have got any questions.
There is a one question.
Yeah.
In critical care, they discuss about rule of while maintaining fluid, lesser fluid means euvolemia, relatively lower volume with lower PO2 around 50 or PO2 around 60. Here in rule of 100, we are maintaining slightly above, like hemoglobin around 10 rather than 7 to 8 as we think about critical care, we think. And urine output 60 ml per hour, it is almost 100 ml per hour. PO2 60, it is 100 here. Why it is so? That was the question.
See what happened. they don't want to compromise any even lesser dysfunction of any organs here. See, critical care about outcome over 7 days outcome, 40 days outcome, that's what to aim that even this level management, there is no outcome benefit in the patient perspective. But here the donor organ will be subjected to various stress in the near future. For example, cold ischemic time, warm ischemic time, so that they don't want to initiate even little insult. Micro insult also should not happen on these organs. That is the reason why they want normal delivery of oxygen through normal hemoglobin. There is no contraindication. They say aim for that. See what happened in our practice in case if HB is around 9, 8.8, we won't transfuse. We don't want transfuse unless that active bleed, unless HB is really less than 7. We don't transfuse adequately. But oxygenation, they want maintain around 100 because the chance of these people going for rapid deterioration within short time, expert DI, hypokalemia, VT, all that is a little very high. Maybe combination of all this, the donor very short time only manage. You're not managing for 7 days, 10 days waste of resources within maybe 12 hours, 24 hours. That's what they may be suggesting to maintain this.
Another point is the graft success. No, it is very high when we maintain all these parameters around 100. Because one of the main objective of maintenance of this organ donation is the well perfusion. No? We have to maintain the adequate perfusion to all the organs, and the graft success will be very high.
What about while taking the lungs? In that case, also you maintain slightly higher volume.
Yeah, see, higher means volume, higher PO2.
Higher volume, fluid.
Yeah, no. See, that's what. See, that when we managing, it's a lung team say give less fluid, give one Lasix before shifting. You stop the IV fluids. See, what happens when that's what we won't give much fluids. As critical care, also we slowly are changing our practice now. No, so we won't give much fluids nowadays. So, but see what happened, unfortunately, if the patient is managed, some other hospital or 2-3 hospitals are coming to us, by the time develop DI, they will be dehydrated. We don't know how much to chase actually. Sometimes we give 4 to 5 liters within 24 hours when the sodium is sitting at 180, 160, something like that. So now we give adequate fluid. That's why I'm saying that in case naturally able to give water feeds through NG, it is better than give IV fluids. In either normal critical care, what you see that, the third spacing should not be there. But we see most of the people develop third spacing, but intravascular volume absolutely will be less. See, sometimes what happens when we do the apnea test, the patient may be more vasopressor requirement. By the time going close towards the donation rates, donation time, organ retrieval time, sometimes their vasopressor requirement slowly come down. When they slowly come down, we stop the IV fluids, continue only NG feed, and start dehydrating the patient little bit. If the PF ratio is very, it comes less than 350 or something. See, if the PF ratio, for example, is more than 450, your airway pressure is less than 15 with adequate tidal volume, we don't bother much about the fluid status, fluid status. If the lung is little getting wet, your airway pressure jumped from 15 to 25, then we realize something happened in the lung may not be fit. So that case, we recruit the lung, we dehydrated them, and do the frequent lung ultrasound and see any B lines are disappearing, then we go for organ harvesting. So when the lung team is not interested, then what happened? We freely give fluids, because until harvesting of kidney happens we want at least 100 ml, 150 ml urine. More the urine goes, the kidney outcome is very good. So that we do that way. Liver and kidney team want to reduce the vasopressors and more fluids. Where the heart team also want more fluids, less vasopressors. Whereas lung team don't want vasopressor, don't bother about vasopressor, give less fluids and dry up the lungs. So that we depends upon which of the organ being harvested, we modify a little bit practice.
Exactly. When they are taking this multi-organ organ retrieval, its judicious management of this vasopressors and fluids plays a very important role.
Yes.
Okay. So what about the evidence for this thyroid hormones replacement therapy?
See, there is the article showed some evidences. See, what happened? They saying that it is maybe like any other critical patient is a sick euthyroid state only. It is a controversial whether to give so much dose, whether this dose, what they're saying that it was helpful in some of the, cardiac unstable patients. It was helpful, especially steroid and thyroid. Thyroxine replacement helpful. In our case, we give 300, to 400 every 8th hourly. We don't know how much. There's no measurement whether whether changes your thyroxine levels of free thyroxine level and TSH level. But what we think, we didn't see any harm in that. We didn't see any harm in that.
Another point is, see, when the of LB dysfunction, when we supplement, when supports are very high, when we supplement this L-troxin 300 micrograms, dramatically the vasopressor support may come down after administration of this thyroxine supplements. And anterior pituitaries, if you look at the evidence, the anterior pituitary is affected only in 50% of the cases as ischemia.
Yeah.
And there are no solid evidences, but definitely the thyroid supplementation brings down the vasopressor requirement, especially in LB dysfunction patient.
What about the steroid? You told almost 1 gram per day, and studies have mentioned 1 gram per day for several days.
No, not several days. They see what happened. They've written as we can give 1 gram stat and 1 gram per day until retrieval. See, what happens, sometimes retrieval won't happen immediately. Some family denies that, they wait for 3 days, 4 days, 5 days also. Sometimes we harvest after 7 days also. That patient cannot receive 7 grams over 7 days. Even infusion is very larger doses. So what we give, sometimes if there is we give 500 milligram one stat and wait for, in case instability only, we revise the next dose. And basically, this steroid is very helpful for the recipient side, not the donor side, actually. Basically, recipient side rejection will be less. That's what, ideally speaking, it should be given 500 to 1 gram just 6 hours before sending the patient to the OT for the retrieval. So what we give, if it's long, we give on 500 before, maybe after 2-3 days later, the night before harvesting, we give another 500 milligram.
Okay. Is it not increases the risk of
secondary infections? Yes, of course. Secondary infection. Sometimes we see they go for hyperglycemia also. See, this is only this article.
What will do
only
if there is
for
infection?
Pardon?
What will do if there is a bacteremia is there? Then do you want to wait for bacteremia to resolve?
No. See what happened. See what happened. Even the one donation which happened yesterday, blood culture came positive. But patient doesn't look like, he's look like septic, maybe the line sampling, it's maybe colonization. That's what we just changed the line and treated with the antibiotics and told the team, retrieval team, that he is culture positive so that they will continue the same antibiotic post-operatively also. Many times it happens. See, if there is sometimes bloodstream infections, they will be very toxic. We have seen our practice very toxic. Most of them, the line handling is poor, and just change of line with maybe 3 or 4 course of antibiotics. 4 times of antibiotics, we cure them actually. They're saying the bacteria is not absolute contraindication. As long as it's treated at least 24 to 48 hours.
So I have a few questions. If sir is okay with it. You just mentioned at the beginning that after 60 minutes of CPCR, you have been able to take the patient for transplant, the donor. So how do you ensure that you do effective CPCR? Because 60 minutes of effective CPCR
see what yes, ma'am. What happened? This is an experience what we had. That's what even See, the patient, we were there, the patient supposed to be shifted for morning 6 o'clock for organ retrieval. And around 12 o'clock, patient had a cardiac arrest. So anyway, patient had an arterial line, you know. So because arterial line is the best to monitor and your UTCO2. This arterial line, well established concepts. Your arterial blood pressure maintained and UTCO2 maintained during the CPR. That means circulation is very good maintained. So what happened? We were continuing for 1 hour. He's just an 18-year-old boy, absolutely fine before, and he had a sudden cardiac arrest without even what's happening there. So we did a CPR. We didn't want to give up. It went on between 9 to 12 o'clock to early morning, 1 o'clock. We did a CPR. Some 8 staffs were there, Simon doing. After 1 hour of CPR, heart rate came back. Then triple vasopressors, 100% FiO2 requirement. Then we proned the patient for 48 hours. We proned the patient. And at the end of 48 hours, his requirement came to 0. Vasopressor requirement came to 0. And your pulmonary edema completely recovered and the lung also was pristine for harvesting. Then we found out what happened. The nurse added a 20 millicurie of KCl in the IV fluids and opened up. It is a hyperkalemic cardiac arrest. We told her to give potassium. She misunderstood and given in the, it's just added 20 millicurie in the IV fluids. And when the patient is hypotension, it's opened up. See what happened. That's what from the day we decided potassium should be given only in the syringe pump, not to just put in IV fluids. Since he was young and he had a hyperkalemic cardiac arrest, in front of our eyes it happened. And see, he had ETCO2 monitoring and invasive blood pressure monitoring. We were able to do, appropriate CPR for 60 minutes and able to donate the organs.
Okay, so this is in a head injured patient, right?
Yes.
RTA patient.
Yes, RTA
okay.
patient.
Because in UK, they used to use the CPCR
Machines
what
external.
is it called? Machine, yeah, automatic.
Yes, automatic
which they straight away used to use that every time
yes,
the arrest happens.
Okay. But India,
so
we
that
are
would
not
be
bought
effective.
this machine slowly coming up. Few hospitals has.
Yeah,
but
it's quite expensive, I guess. Yeah. And on the same lines, how do you maintain normothermia after ECMO? Because that also involves a lot of invasive procedures.
Yeah.
I mean, for the benefit of all the audience.
Yeah. No, actually, see what happened. Monitoring is very important. You should not rely on your digital monitoring or skin temperature. Nasopharyngeal probe or rectal probe is important. Here, prevention of hypothermia is so important than the treating the hypothermia. From temperature once reaches 31, 32 is very long to come to the level of normal temperature. So prevention is very important. Then, see, normally what we do, you would warm blanket and set a temperature 42 degrees Celsius and keep doing that. And fluids, especially IV fluids, can be warm and give, and your NG feed can be warm and give. These are the things what we do that. And if the patient is on an ECMO, we can through that circuit also you can warm the patient's blood.
Yeah. And what about the time for retrieval? You gave the time for retrieval for organs like solid organs, all the solid organs. What about cornea and other tissue harvesting? What is the time?
No. See, what happens now, except brain, everything can be donated. Face, skin, all tissues can be donated. So slowly we're increasing. Now, for example, apart from the solid organs, the tissues normally what we retrieve is a cornea, eyes, whole eyes, in fact, skin, and we just got a license to harvest bones also. Bones.
Okay.
So there is no timeline for that. See, for example, after the harvesting happened, your eyes should be harvested within 6 hours. So that most of the harvesting of eyes happen on the OT. Once they take an organ, eyes will happen, followed by skin team will come and take a skin, and bone team comes and remove the bones, especially your femur, humerus, and the tibia. They remove that and they replace with the implants. Temporary implants. Tissues up to 6 hours, I think we can. The storage, what happens in Victoria, we have a skin storage where they store up to 1 year, for, burns patients.
Skin
The
banks.
bones, the skin banks and the bone banks also started now. TTK have the bone bank. They're saying that they can keep it frozen and keep it for years together and make it powder, and you can use for molding the pediatric or any whoever needs bone grafts. We can do that, seems.
Okay, that's interesting. And if the patient has seizures, how do you manage both anti-seizure medication and brainstem testing?
No. If somebody's having a seizure, it's not a brain death. Brain is still viable. We cannot do that. Is it if the patient have epilepsy, it's not a brain death.
Yeah. So you also mentioned that you take up patients who are HBS positive as well, and you manage with antivirals in the recipient. But in the recipient, you also have to give immunosuppressants. Does the match? Does it match?
No, ma'am. I've gone through a lot of articles. We had a couple of patients, HBsAg positive patients, and we successfully, gone through the article. And they're saying that if somebody HCV positive, HBsAg positive, they're saying this is almost completely treatable. Even HIV in that case matter. See what happened. We give antiviral drugs for the donors, 2 to 3 days for the donors, and the same drug will be continued in the recipient. For example, now we healthcare professionals, we have a pinprick injury. From HIV patients, we have pinprick injury. Your HBsAg patient HIV, we are not going to die. We have a, post-exposure prophylaxis. The same thing we can do, give to the recipients, and we can successfully do the organ transplant.
No, but the difference is, the difference is the recipient will have to invariably receive immunosuppressants.
Yes, even then we give them immunosuppressants along with the antiviral drugs. They may need a little prolonged antiviral drugs. They can, and we explain the risk to the recipients also. You don't blame them. We tell them the article supports, because this is to expand the donor pool. That's what they're doing. All that actually DCDs. These are all the borderline pool patients. If somebody have HBsAg, HIV cross infection happens, the life expectancy comes 5 years down, because normally graft survival is 20 years, they survive only 15 years. Instead of the patient here dying within a month, he can survive for 15 years. That's what, the world body who into the liver transplant, they come as a clear-cut guidelines. HIV positive, for example, now COVID positive, now article has come, COVID positive patients can donate except the lung. Now we take all organs for successfully transplanting them without cross-infecting the patient. Article has come, a lot of article has come. Same thing for HCV, HIV, HBsAg, it's been done.
I mean, will it be during the COVID positive status or after treating the patient?
No, COVID positive, active COVID positive.
Active COVID, okay.
Because yes, it is not bloodstream infection, it's a purely lung. When we search article, lot of organ transplantation successfully happened without secondary infecting the recipients when the donation happens from active, recently treated. Because most of the people are vaccinated, they have some immunity. Recipients have immunity, donor has immunity. But for example, if the patient have, if active COVID infection with the ARDS, definitely we cannot do that. We are not even able to do the brainstem death studies on them, because by the time they have liver dysfunction. See, they're saying that COVID positive asymptomatic patients, not active pneumonia patients, no.
Right. And the kidneys, after they become ATN go into ATN, and then you harvest, how long do they take to recover, or the patient recipient has to have dialysis?
Say anybody 3 to 6 weeks, they say. 3 to 6 weeks they take
3 to
time
6
for
weeks.
ATN complete to recover. Until
Yeah.
then, they need a
Are
dialysis.
there any patients in your experience
Yes, yes, yes.
who have
Yeah.
ATN and
We
then
have.
gone?
We
Yeah, they
have.
have. The
Sometimes what
recipient is
happens.
doing fine, is it?
Yes, they're doing fine. See, what happens now, even intraoperative any complication develop, patient develop ATN, ATN. And they don't
Yeah.
immediately, even the normal kidney up to the OT retrieval happens, ATN develop on the OT because of, prolonged ischemic time. The patient eventually end of second week, they start opening of the, urine output and they recover very well. But we have to make sure periodical, your kidney ultrasound and Doppler to make sure there's no thrombus sitting there and blood flow is fine. All that you have to make sure.
Yeah. Okay. And the final question. This is these kind of scenarios. Patients will be very prone for inflammation, and they have got a procoagulant status. So if they have this kind of procoagulant status and they are bleeding, apart from blood products, do you have any other strategy to manage?
See, mainly what happened, any head injury patients, we see them, we see them, the platelets dropped down less than, 150,000, all that. Normally in the ICU, in the patient with head injury or IC bleed, normally we don't give, prophylaxis, DVT prophylaxis, anything up to, they're saying 48 hours. But from day one, put them on, for DVT prophylaxis, we'll put them on, DVT pump. If the other case bleeding happens, especially once they develop DIC, bleeding happens, many times you won't proceed with organ donation because the DIC with I don't have much experience with that because I never done that, because the once bleeding happens everywhere, organ dysfunction, automatically other organ dysfunction also happen. They want pristine organ for transplant, harvesting and transplant. By the time when you have complete your DIC develops, your lung have some ARDS, severe hypotension happens, and you have liver dysfunction, kidney dysfunctions, not even we proceed with organ donation, especially patient with bleeding diathesis. So no aggressive like other product transfusions, activated proteins, whatever 7A factors, all that, no, because see the donor maintenance itself very costly. We won't invest so much on them, to further worsening, because it's not sure, until patients organ taken and transplanted, you won't know whether the organs will be utilized. So that investment on the donor, it is very important. Every hospital is investing on the donor because of successful outcome. So we should be very careful not to waste money and chase them actually.
Makes sense.
Yeah, because what happened, this all transplant will be, in the DIC, there'll be microthrombi happens, all small vessels.
Correct.
What happened, there is an entity called primary non-function, PNF, the liver was fantastic, the donor. Once the transplant also went on very well, never taken off. Nobody knows why PNF happened in that, body just like reject, and very difficult to manage them also. So that's what to see what happened. It is, a lot of money involved, the life of the recipient involved, so that they'll be very, very careful. That's what we have committee, committee to approve liver. Yes, can be taken. Every committee is there: liver committee, heart committee, lung committee, kidney committee. Recently, they added our committee, like brain death committee. We help them to manage the patients, helping them to, declare the patients successfully. We do that.
Very interesting. And are there any, hopefully this will be a very rare kind of situation, pregnant patient with a viable fetus, brain dead. Are there any guidelines at all? I mean, apart from
we have done. I have done 2-3 patients have done.
Oh, okay.
2-3 patients have done. Sorry, 2-3 patients have done. See what happened, especially most of them on trauma. So where what happened? only one, I think, if you remember, it was viable. Other two are IUD, intrauterine death. So we induced the IUDs, delivered. Then we declared brain death and went on for organ donation because of 2 lives involved, 2 lives involved. So that we deliver the baby, then mother is free of the fetus. Then we did a organ donation. And one patient was brain death. It is more than 7 months viable. So we did a cesarean section, and we tried to save the baby. I can't remember whether the baby is alive. I don't know, but you will remove that, and we went ahead for organ donation in mother, brain death mother.
I mean, in the other case scenario, would you be able to prolong the pregnancy until term if it was?
See, very difficult because
feasible.
after the brainstem death, very difficult to manage them more than 7 to 10 days. More than 7 to 10 days. Though the literature says they can survive even little longer. See, what I think, if you remember, that case is more than 7 months, so that we gave some steroid for maturity, lung maturity, for waited for 48 hours.
7 months they can easily survive.
Easily, we can survive. We did actually. I think the literature says, if somebody is on 1 week, 10 days, we can push up to that. Up to the viable, I think I don't remember this, but it can be done if, as long as mother is stable, or we can.
Interesting. Thank you so much for all the
Sure.
answers. All the questions that I bombarded you with.
No problem. Yes, pleasure.
Very interesting. It's all a very. You do a fantastic job, really.
Thank you, Dr. Chinadurai. It was really excellent discussion, and last 3 topics are very interesting. Maybe because of such awareness, we are able to increase organ donation in India from 0.05 per million to 0.8 per million. That's what that article, that Indian Perspective article has shown. So we are, we are nowhere actually. We are compared to other countries, like it is 26, 25, 30 per million is there. So it's a long way to go. So whatever you are doing, great job actually by creating awareness. Hope this, whatever we discussed last 3 topics, it will be recorded and it will be in the YouTube, so that other people who are not able to attend can utilize this, interesting, information. So thank you once again for Dr. Chinadurai for your, precious time. In spite of your busy schedule, you're able to manage these 3 days. And also other panelists, Dr. Ramkrishna was want to leave actually because of some emergency, left in between. And also I thank Dr. Rajini Patange and Dr. Mohan Kumar, and also Dr. Mahadev for giving opportunity to ISCC Mysore chapter. And also Remedy International, Anup, Shravya, thank you so much for being here. Thank you, Dr. Chinadurai. We will trouble you in case further need is there.
Sure, please, it's my pleasure. Thank you for the opportunity to educate,
Thank you.
Thank you, Dr. Rajini.
Thank you so much.
Thank you so much.